Go ahead and start. This is the first annual International Emergency Medicine. So they asked me if they could do bring in some speakers to do international medicine, and this is certainly an area that's near and dear to my heart. But when they throw the word annual in front of it, I mean, that's a commitment. It's just, it's just south of I do. But it's something that when Christiana and Arun and Dan Radelman came to me and said that, they'd like to start an International Emergency Medicine Fellowship, I'm all in. I think this is probably the best fellowship as far as a true mission of any of the fellowships that are out there. I've been on 8 different missions, and how many have you been on missions before? Not bad, not bad. You get more out of it than they get out of it, and the one thing I learned is you just can't come in. You have to leave something that's endearing and stays there well after you leave. But from a altruistic standpoint, I think international emergency medicine is the best specialty, again, because it's giving back and really goes to the heart of the mission of what we're doing and not so much for a career. I would like to thank, first of all, Christiana and Arun and Dan for putting this together. The signage is excellent. If you get lost in the hallway, don't come back, because obviously it's silly. Every 30 yards you've got a sign. I'd like to thank our speakers for coming out. This should be an excellent and engaging conference. And without further ado, who's the first? Arun?
So I'm here just to introduce our first speaker, Terry Mulligan. Terry Mulligan and myself have known each other like face to face, but not personally. But I went to India to give a speech around 2 years ago, and that's when I met Dr. Mulligan. And I've always wanted to have him come over and talk, because he really impressed me with his speech at that time. So Dr. Mulligan is an associate professor of emergency medicine from University of Maryland. He finished his degree residency and then completed his master's in public health at GW. He's had 15 plus years of experience in emergency medicine and international emergency medicine. He's assisted in establishing emergency medicine residencies, school for emergency nursing, and paramedic schools abroad. He's set relief agencies, hospital disaster preparedness, and hospital trauma system development abroad. He's a board member of the International Federation of Emergency Medicine, Global Academy of Emergency Medicine, African Federation for Emergency Medicine, and he's delivered over 300 lectures all over the world and more than 30 countries. And the best part is he grew up locally in Grosse Pointe. So let's call him up.
Bigger screen, right? Okay. Well, thank you. Thank you so much for the invitation. Thank you so much for the chance for me to come back. Can everybody hear me here? Okay. So my name's Terry Mulligan. I'm an emergency physician, and had some additional training afterwards in international emergency medicine. I actually grew up in Detroit, between 6 and 7 Mile, between Mack and Warren. And then I went from Detroit to Grosse Pointe, about 1 mile away, and graduated in 1987 from high school there, and then went to University of Michigan for my undergrad and grad school. And I did my medical school in Missouri, and then my emergency training in the Bronx, and then went to GW for International Emergency Fellowship. And I'll talk about that a little bit later. But I'm very excited to be here. I'm glad to be back home, even though it's only 10 degrees or 11 degrees today. So we're going to spend about a half an hour talking about global emergency medicine and global development of emergency medicine, and what's happening in different countries around the world. I don't have any financial disclosures to make, unfortunately. And for those of you who are on Twitter, I have a Twitter handle is @TMulligan. with 3 L's for some reason. But I live and work, I live in Annapolis, but I work in Baltimore at University of Maryland. And if any of you are ever in Baltimore area or Maryland or Washington, D.C., I put this up there for our international colleagues, although they tend to have a better geographical understanding than a lot of us. But it's a very nice place. This is the inner harbor of Baltimore, which has undergone a lot of renovation in the last 15 years. We're famous for crabs and seafood there, so if you come, I'd be happy to take you out for some crabs. And we can show you around parts of D.C. And the university. This is the University of Maryland Medical Center, which is the building. But the University of Maryland Medical System is actually 26 hospitals spread out over the state of Maryland. And 2 out of 3 people in Maryland get their medical care at University of Maryland Medical System. And our emergency department covers 14 ERs in the state of Maryland. So we have a pretty big academic program. And this is where, I don't know if you can see, this is the University Hospital. This is the oldest medical school building in continuous use in the USA. We still have lectures there and ceremonies, but it's been in use since 1810. Right here is the oldest dental school in the U.S. It's also the oldest nursing school. And Baltimore is the home of the first postgraduate residency, which was actually started at Johns Hopkins. And shock trauma is about right here. It's a little bit off of the screen. So if you're ever interested in coming and seeing University of Maryland, our department, or shock trauma, I'd be happy to show you around. Not like you need any more exposure to trauma. So I just want to go over a little bit of history of what has happened with emergency medicine, the development of it, a little bit in the U.S., but what has been happening in different countries. And what we've seen really over this century is a change in a lot of things. You know, if you think back over the last 100 years or so, what has actually happened during this last century, there's a huge amount of new technology, of advent of new science. 100 years ago, we weren't really settled on germ theory, and we didn't really have a good identification of bacteria and viral causes of disease. And then a lot of changes have happened in modern medicine over the last 100 years. But specifically, what's happened with emergency medicine is we've seen that in almost every country you go to, you need an emergency medicine system. This need for emergency medicine, for acute care, and for acute care system, it's required in every single country, not just rich countries or European countries, but everywhere you go. And I'm talking about modern emergency medicine systems are in need everywhere you go. If you look at WHO data, since 1996, there's been a collection of data called the Global Burden of Disease data. And what this shows is that over these last 100 years, with the onset of new technology and with new population changes and with demographic changes, what we've seen happen in the last 100 years are 3 or 4 things that have never happened before in all of human history. What we've seen happen is the global burden of disease, which is a measurement of which diseases are impacting society the most. We've had a change in global burden of disease for the first time in human history. Now the #1 causes of death in the world are non-communicable diseases. Heart disease, cancer, stroke, diabetes, trauma. These are now among the top 10 causes of disease. So for all of human history, 100 or 200,000 years of Homo sapien existence, up until the last 100 years, the #1 cause of death was communicable disease. Now we have in almost every country, the #1 causes of death are non-communicable diseases. So that's a major change that has happened in this last century, especially in the second half of the last century, which is one of the reasons why we need emergency medicine. Well, how do we know what the reasons are for this change? Well, if you look back along into history, you don't really have good data for what were the causes of death up until recently. So this is old data from London from about 200 years ago. And of course, the data is not very reliable, but what you can see is most of it is communicable disease, infectious disease. There's some trauma in there, but most of the causes of death were infectious disease. Often, people would die of infectious disease at the extremes of age, in under 5 or under age 1, or at the extremes of age, which back then were in your upper 40s or 50s. And people would have causes of death related to that. But about 100 years ago or so, we started collecting better data. So if you look down here, 1900 versus 2010, this is real data from WHO. What we see is most of the causes of death 100 years or so ago were communicable diseases. Some of them were non-communicable diseases, but the majority were communicable. And when you compare that to now this is global data, worldwide data. The infectious diseases in red, with the red circle, are the minority of the causes of death. This is worldwide, putting together everything. Here's another slide that breaks down causes of death by actual diagnosis by year. And the important thing to notice here is this is 1900 over here, and this is present day on this side. And the numbers of communicable diseases are going down and down and down and down, and the number of non-communicable diseases are going up and up and up and up. So if you look at data from 2010, what we see is 6 out of 10 causes of death in 2010 worldwide are because of non-communicable causes: heart disease, stroke, cancer, trauma which can be treated like a non-communicable disease. It has a known cause, known risk factors, has preventable factors that can be intervened upon, and then there's also the secondary prevention aspect of trauma. But it's not communicable, although it can be chronic, as we know. And then look at what the projections are. If you compare 2004 to 2030, these are pretty robust projections. You know, when I was in public health school, my medical school dean was one of the teachers of one of my classes, and he once said, there's nothing as inevitable as public health indices. Meaning, if you want to predict the future, don't look to the stock market or to the business world or even to history. What you look to are public health indices, public health numbers, which are measurements of hundreds of millions of data points, and making predictions of which directions these are going in. And so pretty much one of the best ways for us to predict what's going to happen in the future is using public health measurements. And what these public health measurements show is that by 2030, instead of 6 out of 10, we'll have 8 out of 10 causes of death in the world be non-communicable diseases. So this is showing you that you have good job security in the world as an emergency physician, because this need for your expertise is not going anywhere. And if you just look at one particular disease itself, trauma deaths, and not just trauma deaths total, but trauma deaths from car collisions, goes from number 8 to number 3 in the world, only in the next 15 years or so. So what that tells us is we really need to focus on building acute care systems and emergency systems to put ourselves in a place where we can handle these diseases that are coming down the road. So when you put all the numbers together for a global burden of disease, what we see is 63% of causes of death now are due to non-communicable diseases: heart disease, cancer, stroke, diabetes, and trauma. There are only a handful of countries in the world where the #1 cause of death is still communicable disease. So that's one major change. Why did that change happen? Well, we've seen a couple things happen. We have this gradual graying or aging of the world's population. If people don't die of infectious disease at under age 5 or under age 1 or around maternal or perinatal mortality, if that goes down, then you wind up surviving to die of something else later. And so we have people living to much older and older age, and that's happening in almost every country. These are UN data that show this is the way most populations start out. Most populations start out with lots and lots of young people, and not so many middle-aged people, and then hardly any really old people. But what's happening in modern societies is as countries become more developed in their economics, their public health, their education, their nutrition, that people, starting to have more and more middle-aged people and more old people. And there are some places now, like this is where the U.S. is, the average age is 45 or 50. That's higher than the life expectancy in some of the least developed countries right now. And the fastest growing segment of the population in almost every country is the oldest segment. And then there are some countries in Europe, for example, where within the next 10 or 15 years, there'll be as many people over 65 as there are under 65. And that's never happened before in human history. So what kind of medical system do we need to have in place to handle that type of change? And what we see is that this transition from a young population to an older population is happening the fastest in the least and middle income countries, which are places that are exactly the least well developed in terms of their medical systems. And this is happening in almost every country. So we have the world population getting older and older and older, and as you know, people who are 50, 60, 70 have different diseases than people who are under 10 or under 20 or under 30. And in the diseases that are similar, like trauma, their bodies respond differently to those diseases. So we need a special system to be in place. So it's interesting to think there's a Native American proverb that said we are borrowing the world from our grandchildren. We are the caretakers of the environment and the world for our children and our children's children. And we're handing the world over to our children. But the demographics actually show something different. So you have to ask which way is the globe being handed off. It's kind of like the older population is not wanting to let go of it now. We see that in what's happening with medical care. So over the next, it's estimated by 2050, 1 out of 5 people in the world will be over age 65. So those of you who are in emergency medicine, we know that the big majority of our sickest patients, our admitted patients, our ICU patients, our complicated patients who actually need an emergency medicine specialist, these are geriatric patients. So you guys actually are all geriatric emergency physicians without even realizing it. And that's going to become more and more and more as you go forward. The other major thing that's happening is in 2006, it was estimated in October 2006, and it was actually the day before the ACEP meeting in New Orleans. It was estimated that one person moved from a jungle or a rural village into a city, and that tipped the world's population from being predominantly rural over to predominantly urban. So they estimate now there are more people living in cities than who don't live in cities. And that's never happened before in human history either. So now we have the majority of the world's population. Globally, it's about 56 or 57%. But in some countries, it's much, much higher. Like in the US, it's about 75, 77% of the population lives in urban areas. And in some countries, it's up in the 90s live in urban areas. And when people go from a rural lifestyle to an urban lifestyle, you change your habits, you change your work style, you change your eating, you change your outlook, and you get different diseases. So there are a lot of these reasons that you see. The gradual aging of the world's population, urbanization, and changes in socioeconomic status and public health. All of this is pushing this non-communicable disease burden, which has never happened before. And almost every country, you're seeing people moving from the rural areas of those countries into the urban areas. So when you put all this together, what has actually happened in terms of emergency medicine? If you look around the world, emergency medicine is the second or third youngest specialty in almost every country. And in half countries of the world, emergency doesn't exist as a specialty at all. Those of you who are in the room who've been practicing emergency here, like your chairman and some of the older doctors, might remember the early days of emergency medicine here in the U.S. This is the lifespan of emergency as a specialty in the U.S. is about the length of a career. There are people who are still practicing now who, excuse me, who are still alive now, who were practicing before emergency medicine existed in this country. So it's not ancient history. This is a process that's happening even now in the U.S. So when you look around the world, what you see is emergency medicine in different stages of development. And there are some ways of lumping this together in three different categories. You can have the developed emergency systems, the developing emergency systems, and the underdeveloped emergency systems. And there are only about 5 or 6, 7 countries, depends on how you measure it, but there are only a handful of countries where emergency medicine is fully developed as a specialty, as a system. It's embedded into the medical system, and it's parallel, equal to all the other medical specialties like surgery and GYN and internal medicine. Pardon me. A little coffee. So these, excuse me. So these 5 or 6 countries where emergency exists were the U.S., the U.K., pardon me 1 second. Hopefully that's an infectious cause and not a non-infectious. The countries where emergency exists as a fully developed specialty are roughly the U.S., the U.K., Australia, New Zealand, Hong Kong, Singapore, and then maybe a couple others. What I mean by fully developed is the specialties recognized, you have residencies, you have societies, you have research, you have government support, public health support, policy support, economic support, the payment systems. There are 30 or 40 different variables that you can use to measure. Does your country have these variables, and in what state? So there are about 5 or 6 countries. Then there are about 30 or 40 other countries where emergency is still developing. Excuse me. These are countries where they have some of the things that are required, but not all of them. Is there a water or something? Excuse me. So there are 30 or 40 other countries where they have some of the elements of emergency development, but not all of them. Some of those are residencies. They might have some residencies, but not all of them. They might have a specialty, but it's in its early days. They might have a society, but the society was just developed. And there are maybe 30 or 40 other countries like this. For example, Mexico has over 4,000 residency-trained emergency physicians. But there are 4 or 5 different emergency medicine societies, and their government hasn't kept pace with reimbursement strategies for them. So it's a developed training program, but not necessarily a recognized government system. In Europe, there are a handful of countries that have emergency that's well developed. Thank you. Thank you. In Europe, there are a handful of countries that have very well-developed training programs, but don't yet have full government or status or recognition. And then the vast majority of the world has little to nothing. Most of Central and South America, most of Africa does not have good emergency medicine. Most of Asia, Southeast Asia. In this small area of Southeast Asia, going from about here to about here, there are more people living in this circle than who live outside that circle in the world. And most of those countries, like Malaysia, Indonesia, Thailand, the Association of Southeast Asian Nations countries, they have very little emergency medicine development. So we have a long way ahead of us. What has actually happened is the number of countries who have emergency medicine as a specialty has gone up. Starting in about the mid-60s, there were 1 or 2 countries, the US and the UK, that started recognizing training programs, started recognizing the specialty, and to set up the original societies of emergency medicine like ACEP. And it went kind of slowly over time. And now what we see is this number changes every year. We now have over 60 countries that have emergency medicine as a specialty, with 2 or 3 or 4 countries being added every year. The specialty recognition by the government recognition bodies tends to be a key and crucial step, but it's not the only step. Specialty recognition is usually helpful for government funding and for acceptance by the other specialists, but it's only one of many different steps. So when you put all this together, what we see is that around the world, emergency medicine is really a work in progress. This is a picture of the Brooklyn Bridge, which took 13 years to build. And the Brooklyn Bridge has no function until you're done building it. But emergency medicine actually starts to work before you're done building it. So what we see is some places in the world have good functioning emergency medicine, like the US, although we still have a lot of work to do. We still are expanding. We still don't have enough emergency doctors in our country. There are some places where they've begun this process, but they haven't finished it yet. But the vast majority of the world has not even begun this process of building their emergency systems. So what happens when you look around the world, when you go from one country to the next country to the next country, is you start to see these patterns. You know, if you go to 2 or 3 different countries and ask, what is emergency medicine like in this place? You feel that, you notice that they're kind of different. But if you go to 30 or 40 or 50 different countries, you start to see, well, you know, they're really more similar than they are different. The emergency systems, they tend to be more similar to each other. The patients are more similar to each other because of those demographics we just mentioned about non-communicable disease. So places are different from each other, but not 100%. They tend to be different in small, subtle ways, important ways that you have to focus on and pay attention to, but not ways that require a complete rethinking of everything. So the same way you can look at these pictures and kind of fill in the missing gaps, you can go to a country and look at its emergency medicine systems and see where are the pieces that they have established, where are the pieces they might need to expand upon. And when you look at different systems country by country by country, you start to see these patterns develop, patterns that are in common. And for a lot of different reasons, the places where emergency has started to develop, it started to develop along common pathways. The way it was built in country A is similar to the way it was built in country B or C or D, even if those places were separated in geography or culture or language or even decades in time. The way adoption of change happens is similar no matter what it is you're trying to do. So if we're imagining that this is an adoption curve for emergency medicine, having no emergency medicine is over here, like in the 1960s in the US, and having a functioning system is over here, like 2016 in the US. What happens is you work and work and work and do a lot of different development projects. You set up residencies, set up different programs, and nothing seems to happen. and you work and work and work for 10, 15 years, kind of beating your head against the wall, and then all of a sudden things start to change and they happen really fast, and then you get to this, this new kind of level. So this is where the U.S. kind of was, this early adoption stage. During the 70s and 80s, things happened very quickly. We had specialty recognition, we had multiple different societies, we had multiple different training programs spread around the country, and this is kind of where we are now. So from no emergency medicine in the U.S. to a functioning system in the U.S. took about 40 years, 45 years, and we're still kind of still developing. Whereas in other countries, this can take 15 years or 12 years. I think that's about as quick as you can compress it, maybe 10 or 15 years. If for no other reason than the people who are blocking you, it takes 15 years for them to get out of the way. Like they retire or they get fired or they die, and then you kind of just go around them. I'm half joking, but half not. So what we see is when you're building emergency, it's not just the doctor training bit or the nurse training or the paramedic training bit or the specialty. It's actually a bunch of different systems that are built within each other. So if you think about it as this set of nested Russian dolls, that the training program might be down in here. This is where our residency training programs, administration programs, financing and economics, national financing, maybe some legislative support, legislative agendas like EMTALA or prudent laypersons, or NHTSA funding did for us in the 70s and 80s, and public health and public policy. So now we know in the U.S. it can't go back to the way it was before because of all these different systems that were built over time embedded inside each other. But transforming a country that has no emergency into a country that does, it's not just training the doctors. One way of thinking about this is these primary, secondary, and tertiary stages. And this is the pattern that I see evolve or emerge when you look from one country to the next country to the next country. That you can focus on these primary stages, which is building specialty systems, building doctor, nurse, and academic training programs, and then some patient care systems. And when those tend to be in place, you can focus on these secondary systems, administration and management. It's one thing to learn about how to run your ER. It's another thing for your system to learn how to run 50 ERs. Or how does your country run 200 ERs? How do those ERs fit into the rest of the healthcare system? So you learn a little bit more advanced administration and management. And then other things like what kind of legislative support does your country offer for emergency? What kind of financial, what kind of public health? We think every health minister in the world should believe emergency medicine is the #1 priority, but they don't. Some of them do, but most of them don't. So how do we actually influence public policy and politics in order to make it a priority? So this is the system that is very much in common from country to country to country, but each country is a little bit different. It's not totally different, it's a little different. So when you go to another place and they tell you, well, you know, it's different here in Italy, or it's different here in Sri Lanka, or it's different. Yes, it is, but it's not totally different. It's only a little different. Countries have to reinvent the wheel when they're building their emergency systems, but they don't have to reinvent it 100%. Maybe only 20%, because a lot of the answers about how to do it have been done in 30, 40, or 50 other countries. So another way of thinking about the same thing is instead of being a pyramid where you have to do them in order, you do step A before you do step B, before you do step C. I actually like this looking down the road because it puts it into a time frame. Some of these things are short-term projects, things that can be done in a year or 2 or 3 years. The secondary stages are things that can take 5, 6, 7 years, 10 years. And then the long, hard things like legislative support, policy support, those can sometimes take 10 or 15 years. But if they take 10 or 15 years, you don't wait 10 or 15 years till everything else is done before you start tackling them. You have to start tackling them now. Otherwise, you're just going to multiply your waiting time. And then there are other countries where they do need emergency medicine, and in the ways that we've talked about it, emergency medicine as a specialty. But they also need a whole lot more. So we think about sub-Saharan Africa or places in Southeast Asia where a lot of places don't have sheets for the bed, or they don't have running water or food, and a lot of humanitarian crises. There's a lot of other things that those countries need before you start thinking about building modern emergency medicine systems. So while you're building emergency medicine systems, you can also think about other things like basic public health, basic first aid and community first aid programs, basic pre-hospital, and things that can be done in the community, kind of bringing emergency training to that final kilometer, that missing kilometer between the front door to the ER and the place where the people live. That hasn't really been addressed in most countries. And you put these two together, and that's really the whole acute care system. So all these different slices of this training program or this development program, you can think about it like a tiramisu of different layers of training interventions or developmental interventions. And if you put them all into a grid, I used to call it the 30-question hypothesis, but now I call it the 40-question hypothesis. And it originally came from some work done by Jeff Arnold, where he looked at 4 different categories to stage countries. If you ask what stage of development is this country in terms of emergency medicine, he used these 4 different variables to judge whether they were developed, developing, or underdeveloped. And since then, we've kind of added on these 4 more. So these 8 different variables can really describe the state of emergency medicine, and each of these 8 variables has 3 or 4 different sub-variables. So out of the 1,000 problems that you might think your country has in building emergency medicine, if you sift them all through the sand sifter, they all come out into about 8 different categories. And each of these has a different time frame and time scale. So ways of implementing this in different projects, again, looking at as a development curve, going from lots of hard work with not a lot of response or nothing to show for it, to a quick change to a new level of equilibrium. Ways to do this are, let's say, over 5 years, are some of these things we're familiar with, having, let's say, annual conferences, annual symposia, meetings of the national societies. Inside countries, we can also have CME training programs in clinical pieces of emergency, but also non-clinical pieces like administration and finance. Of course, in every program, we have our weekly and monthly training programs like we're familiar with in our own residencies. And then, of course, there should be daily supervision and training that happens on a doctor-to-resident focus every single patient. So when you do those different things all together like this, it takes this learning curve and shifts it from here to something like this. So it still takes a little while, but you're getting, instead of a long flat part of the learning curve, you're getting kind of a steep rise. And we've seen this happen in a bunch of places. We have some colleagues in Middle East and UAE, for example, who've used this concept of how to look at the states of development in their own system and ask, well, they seem to be doing pretty well with residencies. They have the specialty. They have a society. They have some administration training. But they've noticed that they don't have any good high-level government support. They don't have good financial or administrative or policy support. And so that way they can know what area to focus on over the next upcoming years. Just to wrap up for this segment, why bother doing all this? Why bother building emergency medicine? Well, I think we've talked about the need. The need is definitely there. But when you build emergency medicine, does it actually help? Well, there's a lot of good evidence to show, yes, it does. When you build the emergency medicine system, and if you just focus on the ER, there's this ripple effect or knock-on effect that happens. When you build a department where the doctors are trained, they're specialists, the nurses have specialty, the ER is built to be an ER, and it's not just an old patient care area. It's function and purpose built. When you when you have people in the ER who know what they're doing, what do you know? The ER works better. Well, we know that, but there are places in the world where they still don't yet believe that. They think they have a good emergency system when in reality they don't. So when you fix the ER is fixed. But when you fix the ER, it also helps fix the hospital. And it helps the hospital function better because you're delivering people who are not as sick to the hospital. You're diagnosing that MI now instead of tomorrow on the ward. You're catching that trauma or that surgical problem and sending them into the operating room instead of losing them to follow-up. And so when you have the ER function better, it helps the hospital function better. And when the hospital functions better, all the hospitals function better. And that helps with national secondary prevention, secondary disease treatments, and also with this overall non-communicable disease burden. It takes about 5 or 10 years or maybe more for these ripples to reach all the way through the healthcare system, and it takes a little while for people who measure these things in public health and health economics to be able to measure them. But in places where it's been measured, you have this huge benefit to the whole healthcare system. And for this reason, emergency isn't just another specialty alongside all the other 30 or 40 specialties. It's a new specialty. It cuts across them. It's a new way of thinking, kind of a new paradigm in emergency in medical thinking. It's for these reasons that you really need to have emergency development country by country by country. So that's my talk. I hope it's a good overview. We're going to talk about a couple subtopics in this as we go through for the rest of the morning. And this is my email and my Twitter, if anybody's interested. Thank you. Thank you.
So I'm sure you guys have a lot of questions. So I put the question cards out there. You can write it, and like after 2 or 3 lectures, we'll ask questions.
So it's fellowship now, right? This one's much shorter, so I won't go over time. Okay. So we'll spend the next 15 or 20 minutes talking about what to do about it. I hope I gave a little overview of what's happening in terms of emergency medicine development in country by country by country, and what we've learned through experience, through training, and also from trial and error over the last 15 or 20 years. But how do you actually get involved? Can I ask you to raise your hand? How many are emergency residents? How many are residents in other areas, other specialties? And how many are medical students? Okay, good, good. And do we have other professionals here, nurses, medics? So mostly residents and students. Okay, great. So how do you actually get involved in global health or international emergency medicine? When I started, I still call it international emergency medicine because that's what it was called when I did my international training. But things change over time, and a lot of places call it global emergency medicine or global health, global acute care. But the concept really is, how do you build emergency systems in other countries, and what kind of training and experience do you need to do that really well? I'll just spend 10, 15 minutes talking about the concept of international global emergency medicine fellowships and how I got involved, and how possibly you could get involved. Again, I don't have anything to disclose. I have a lot of things that I do, but nothing actually pays except seeing emergency patients. So what we'll talk about is the concept of fellowships, Fellowship Consortium, which is a program, a group that we developed about 4 or 5 years ago. And then what's the benefits of having fellowship training? What's the benefit of the Fellowship Consortium? and then an example of how this works. For those of you who want the conclusions first, and maybe you can leave and you don't have to listen to the rest of the talk, the conclusions really are that when you're building emergency in other countries, you really need multi-level, multidisciplinary, multi-professional strategies. Your residency teaches you how to take care of emergency patients, but it doesn't teach you how to build an emergency system. These are things that they don't teach you in medical school or teach you in residency, but you can be taught those things. Things like public health and health economics and health policy and health law, and these things that are part of that Russian doll system I just mentioned. So you really need to think about the different layers and the different level of expertise you need to intervene on these different levels. And a fellowship is a really good way to get some of this education and training. Just the way you can become a surgeon and then do a fellowship in hand surgery, you can become an orthopedic surgeon and become a fellow in spine surgery. You can do an emergency medicine training program and do a global emergency or an international emergency fellowship and become a subspecialist in how to build systems in other countries. So just some talk about the nomenclature. What's the difference between a fellow and a fellowship? Well, it's not always clear. Fellowship, what is it we're talking about when we're talking about fellows and fellowship? So some of you might be fellows of ACEP or fellows of AAEM or fellows of ACOEP, and that's usually a mark of distinction that you get by joining a society, and often there are pretty strict requirements for who can become a fellow. It's kind of a distinguished member of a society, and that's important, but it's not what I'm talking about here when I say fellowship. It can also be someone who's had a level of academic or educational achievement. So, for example, to be a fellow of the the Australasian College of Emergency Medicine means that's the same as being board certified in the U.S. So if I'm a fellow of ACEP, that doesn't necessarily mean anything in terms of my academic, it's a recognition of my academic training, but it itself doesn't have a government status. Whereas in Australia and some other countries, the UK, being a fellow of those colleges means you're their equivalent of a board certified emergency physician. And again, I'm not talking about those here either. What I'm talking about is this, fellowship as subspecialty training. And you'll notice that some countries use the word fellowship to mean different things. So sometimes they talk about their medical students as being fellows. So it just helps to know what it is we're talking about. So what I'm talking about is subspecialty training programs, training after your residency. After your residency is done, going into a 1 to 2 year program that is either officially recognized or not officially recognized. And some of them are recognized, like ultrasound, pediatrics, EMS. And some of them are not recognized. Some of them are not yet recognized. And some of them probably never will be or don't need to be recognized, like, let's say, wilderness medicine. In the U.S. now, there are about 40 subspecialties for emergency medicine. That's great. 40 different areas that you can think about becoming a subspecialist in after your emergency training. Some of them are official and ACGME recognized, and you get a certificate and a government or state government recognition. Some of them are not. So the question you need to think about is, what is it you're interested in, and do you actually need that type of certification? So this is what I'll be focusing on, this concept of subspecialty. So you can find a listing of these 40 or so subspecialties for U.S. emergency doctors. One place is SAEM.org. This was taken about 3 months ago, so I think the website is still similar to this. But if you go there and look where it says fellows and pull up the different types of fellowship programs, it lists them all out. There are about 35 or 40 ones, and one of them is international or global emergency medicine. Where are these different global emergency medicine fellowships listed? They are listed on SAEM. They're also listed on epijournal.com. This is our magazine that has a pretty comprehensive list of where the fellowships are. And you can look at that online or on paper. And then there's also a new website I'll talk about in a second that shows where all the official fellowships are. And when I did my fellowship in 2002, there were only 6, but now there are over 40, and they're in all over the country. What are these programs? They're international. They're training programs after your residency where you go get extra training in how to build emergency systems. You work as a faculty in the department, usually half-time or maybe 2/3 time, but it's a reduced faculty hours requirement. Often the training programs have a graduate degree component to them, so a graduate degree either in Master in Public Health or in global policy, or in a lot of places are flexible and you can either not do a master's degree or you can pick your own master's degree. And some of those are 1 to 2 year programs. But the interesting thing about this is that it's extremely attractive to your residency program to have an international profile and to have an international program. Even if not all of your emergency residents or doctors are going to graduate and go into international. Because there are a number of different papers that have, studies that have been done that ask when doctors are applying for emergency medicine residency, what is it that they're really interested in? International or global project involvement is always at the top of the list. So even if the only thing your program cares about is attracting the best residents for emergency medicine, it helps you to have an international program. Because most residents, most students, they're consistently listing global health as the number 1, 2, or 3 on their list of interests when they're applying to different schools. Now, we think that there's a lot of other reasons too, but this is one reason to think about having an international program. When you look at students, now it's about 10 to 15% of all medical students do some kind of international rotation somewhere. There are also now 40-something out of the 160 or so emergency medicine residencies, about 45 or 50 have some sort of international program with a fellowship. There are about 20 or so more residencies that have international programs or projects, but they don't have a fellowship. Whether they want one or not, that's a different question. But so that's about 60 of our residencies out of 160 that either have a fellowship or have an international program, and then a lot more also have individual faculty. So it's about half of our residencies have some sort of international involvement. And so this is a good area for you to become involved in if you're an administrator or director or residency director. This is a good article that talks about what does the impact of having an international program on your residency, what does that do for your application series and your application process? And it turns out you get a lot more applicants, and you get an applicant of a higher academic quality if you have an international program. And it allows you to kind of select from a little bit better resident applicants. So just to go over what these fellowships are, this is a 1 to 2 year post-residency fellowship program. Most of them involve working part-time in the ER, and that's where your salary comes from. Often your salary comes from seeing patients as a faculty. So you are, in almost every state, considered an attending. You're able to see and train residents and sign their charts, and you're treated like a junior faculty, but you're working part-time. It also involves you working in projects. So you're working part-time in international projects, including international rotations or postings overseas. And each program is a little bit different on this. Most of them, but not all, involve some sort of MPH, like I mentioned, in public health, global health, health policy, or take your pick. Just a couple more slides and then I'll stop to talk about what does the curriculum look like in these fellowships. Well, until the last couple of years, there hasn't been a common curriculum. There was a paper that was done not too long ago that looked at all the different fellowships and what their curriculum was and compared them to each other and showed that all the curricula have these elements in common. These are some of the things that you can think about. These are the things that you would be learning if you went through a global a global emergency medicine or an international emergency medicine fellowship. You would learn emergency systems development, which is how do you build the system? You know, the training program, the administration program, the finance, etc. You would also learn about humanitarian relief, disaster management, public health, travel and field medicine, program administration. So not just how to be a director, but how do you direct 20 ERs? And how do you train people to be directors? And then other things like academic skills. How do you teach residents? How do you set up a national curriculum for another country? What's the science behind teaching and testing? So there isn't one program that offers all of these. There are some that offer areas of excellence in many of these, but it depends on what your general interest is. So what this shows us is that a fellowship, most people who are doing global health in emergency medicine think that it probably helps for you to have a fellowship if this is something that you want to do as a career or a subspecialty. So if you know or are kind of sure that you want to be involved in global health on an ongoing basis, probably it's a good idea to do a fellowship. We commonly get asked the question, do I need to do a fellowship? Should I do one? I've done A, B, C, D on my CV. Do I need to do a fellowship? Well, I think in general, if you're going to be doing this for a career, let's say 15, 20 years, it probably helps to have this done. That's just my opinion. And because you learn things that you don't learn any other way. Second, the conclusions for these were that there's probably not one common curriculum that is applicable to every area. Some fellowship programs have expertise in humanitarian aid and conflict resolution and humanitarian assistance, but they might not have good training in that program for, let's say, academics or residency development, whereas other places are vice versa. So there's probably not one program that teaches you the best of everything in everything. Again, the fellowship concept is well, we're coming on 20 years old. The oldest fellowship now, you said 1995. So it's a young subspecialty in a young specialty, and it's still evolving. So if you're interested in this, you can be part of this evolution of not just being a fellow and learning international, but then being involved in determining, well, what is international and how does it go forward? We've noticed some things in the first 10 or 15 years of fellowship development that when I did my fellowship, there were only 6 programs, and we had to collaborate with each other. So, for example, Jim Holloman, who you'll hear from, was one of the reasons I went into an international emergency, and his program at Penn State and my program at GW, we worked together all the time. Almost all of our projects, we had to collaborate with other fellowship programs because there were only 6, and my program was only 4 or 5 people deep. So we couldn't do much of any projects without collaborating with each other. And now that there are 15, 20, 30 fellowships, I think, and some of them became very robust with maybe 5 or 10 different faculty, projects tended to be based at a university. And our bosses always want us to bring home projects or programs or products that become owned by us. So it would be owned by your university and without collaboration somewhere else. That's beneficial for some reasons. It makes your chairman happy, it makes the departments happy, but it also limits what kind of programs or projects you can do. Because there are only so many projects you can do with 10 people. You can't do a major national project that requires 50 people if you only have 10. So, what I think we've noticed in the field, those of us who've gone through the fellowship and learned all these different skills about how to do major, large projects, is we wound up having to answer to our chairman or to our deans or to our school saying, well, that's very well and good what you're talking about, but we only have 7 or 10 people that we can offer to you, and we don't have a good way to take advantage of these opportunities. So in some ways, we're kind of setting ourselves up to fail. You get this training program that teaches you how to do major projects, but maybe your department or your school is unwilling or unable to take advantage of a major project. So what we started to do is figure out ways to fix these problems. So that led to this concept. It started a little while ago in making a parent body for the fellowships. So starting a long time ago, we talked about this Emergency Medicine Fellowship Consortium. So making a parent body for all the different fellowships around the country. So we mentioned about 44 in the U.S. They're setting up some fellowship programs in Australia where they're teaching their emergency doctors how to build systems in other countries. There's some work being done on this in the Netherlands, also in South Africa, and there's an International Emergency Medicine Fellowship in Canada. And so what we have is this International Emergency Medicine Fellowship Consortium, which is a collection of all the different international fellowships so that we can learn from each other. So you can expect the benefits of this program, which is still in its early stages. It's been official now for 4 years, and we're working on a common curriculum. It's the common way to apply for international fellowships. And so what it allows us to do is keep track of ourselves, how many programs there are, which ones are official, which ones are not, how many fellows have graduated, what are people doing. It kind of keeps track of what are our own curricula, what are our own training focuses. Some of the other benefits are it allows us to share our teaching experiences. Often, you go to a country and set up a project, and you don't realize that 50 miles away there's another university doing a very similar project. And you can really go a lot further if you kind of bypass the bosses and try to collaborate with yourselves. And you wind up being a bigger, better project for everybody and probably benefiting your own director better. Other things that can happen are you get better support for new training programs. So if you're setting up a new fellowship, the existence of a fellowship consortium can help you with this. And then it helps promote further cooperation. Some of this competition is healthy, some of it is not healthy. Some of it is we're working at cross purposes. So we can go after bigger and better and more comprehensive projects if, let's say, 5, 6, 7 fellowships collaborate with each other. I see the Fellowship Consortium as kind of a ready, trained army of 44 fellowship directors, 44 fellowship co-directors, probably 2, 3 fellows each program. That's about 100 trained people in the U.S. who've had fellowship training and interest in this, who could potentially be brought to bear on a very large-scale project that we're currently out of reach while we're busy competing with each other. And I think it helps us increase our profile and helps us get recognized by large bodies like the WHO and the UN that we've organized all these things together. So this is the website for that, iemfellowships.com. This is the common way to apply for fellowships now. On the website is a map that shows where they all are. You can click on each one of these, and it brings up the website of that program. You can find out ways to apply. There's a common application form. There's a no offer date that we've all agreed to, so that we're not competing with each other to try to scoop up the best fellowship applicants. We've all agreed. It's kind of like a mini match that we've agreed to. And they're all listed here. They're all listed how many fellowship programs, how many fellows they accepted, whether they're active or inactive. And you can use that to look at. And this last thing is just an example of what could we actually do together. Let's say our fellowship program in the Netherlands, South Africa, and I don't know, University of Maryland, just as an example. We can collaborate with each other and come up with a very big project that would help, let's say, South Africa set up an emergency training program in country A, B, or C. And this type of tiramisu, all these different layers of project development, these can be done. Fellowship A, which might have expertise in academic and setting up residencies. Fellowship B in a different state that might have expertise in humanitarian aid and assistance. And Fellowship C that might have expertise somewhere else. We can all collaborate with each other to have a good product. And so we hope that this would be a way of providing trained, interested experts in global emergency medicine development, providing them as a kind of a service organization for the nuts and bolts of building the other systems. So again, the conclusions, this type of fellowship program gives you multi-level, multidisciplinary training. It gives you experience. You know, I had Jim, who's here, I think he was one of the people who developed the fellowship concept. So he didn't learn through a fellowship, he learned the hard way, which is out there, you know, for 20 years in the trenches. But I was able to stand on the shoulders of people like Jim and other people who set up this program and learn some of what they learned in a training program, as opposed to spending 20 years on my own learning it. Some things you can learn that way. Not everything, but some things. And so these fellowships actually offer that. And it's a good way to provide comprehensive systems development, which we talked about in the first. Okay, so that's the end of my talk. I'm going to be here all morning, obviously. I'd be happy to talk to any of you. I have a lot of interest in this, and this has been kind of a passion or maybe even obsession of mine for the last 15, 20 years. So if any of you are interested in how to get involved or what to do, please feel free to give me an email and come down, and I'd be happy to talk to you. So thanks again, and thanks for inviting me, and it's nice to be back home. Okay, thanks.
Thank you very much. Are we at both places?
Okay.
All right, and for the record, we are now on the website as well. We'll get to that here in a little bit. Next, I want to introduce Dr. Janet Lin, which is an honor for me. She was my fellowship director at UIC. I'm going to go through her litany of accomplishments. They're quite impressive. She's an associate director and a professor at the University of Illinois at Chicago. And also associate professor in the School of Public Health there, and teaches courses, started their global health program at the School of Public Health, basically. She's the director of the systems development at the Center of Global Health at UIC, and the associate director of the International EM Fellowship. She recently stepped down, and the new fellowship director will be speaking here in a little bit as well. Her main projects now are in Haiti and Kenya, and also just stepped down as the international section director at ASAP. Another fun fact, she's also an Ironman ×2. So she's going to be giving her lecture on IEM, and we're very happy to have you here, Janet. Thank you.
Good morning. Can you all hear me? Good. So I'd like to thank Detroit Medical and Wayne State for actually inviting us. This is actually an exciting kind of inaugural conference day for Michigan. I too have some ties to Michigan. I was not born here, but I did grow up here for about 6 years, and I lived in Troy, Michigan, for you guys who actually know. So my first kind of grade school years were here, and my parents actually worked at Wayne State. Not in medicine, though. So I think this is actually a great segue. We didn't necessarily do this purposefully, but I mean, I think the link and the tie between all of our lectures today really will reinforce kind of, what is international EM, global EM, how we actually build upon that. Just as a kind of an aside to really follow up with what Terry had mentioned, one of the biggest interests now in both medical students, residents, and even people within their kind of EM career is actually global health. And as a result of this, as part of my previous role as one of the international section chairs for ASEP, my colleague through SAEM, we actually are in the process of publishing a book called Nuts and Bolts of Global Emergency Medicine, which is primarily, and it's also done in conjunction with EMRA International. And so the goal really was to truly try to provide some sort of resource for students, for residents, for even any person. Does not have to be specifically emergency medicine, but it could be students, as a guide, a comprehensive guide of, what does global EM mean? How do you actually get involved? What's the entire process? And the beauty of it is that it's actually really done in conjunction with faculty and trainees. So the entire book is actually written in concert with the two and perspectives from both of them. So stay tuned to that. I will definitely share it with Arun and Cristiano when it actually gets published. It is going to be open access, so you will not have to actually purchase it. So that was the other intent, is to make sure it has broad appeal and broad reach, not just in the US, but also internationally. So today, for my portion, really we wanted to kind of talk a little bit about collaborations and kind of really what is the role of emergency medicine, specifically in global health. So just to start, I kind of want to try to make this as interactive as possible in a lecture setting, but to try to define what does global health actually mean, and really look at it within that perspective of the health system in which we work as emergency physicians. And then discuss the meaning of collaboration and why is that so important, and then try to identify some roles that emergency medicine plays within kind of global public health through some examples of work that I'm currently doing and things and activities that other partners and institutions are actually doing as well. So to start, when we talk about this, we've been throwing around this term of international / global / health. To you, what is international health or global health? Just shout out some kind of ideas, thoughts, things that come to your head. Health of the globe, okay. And I guess the other thing too is there a distinction between international and global? I think that's actually probably more the important part. Do you guys, in terms of hearing this, we kind of throw the terms around interchangeably, but is there a distinction? Yes or no, you think? Yes, I hear yes. Some people say no. So I think one of the things, just to get an understanding, when we refer to them, oftentimes we will refer to them interchangeably, but there are distinctions, and the important thing is really, as global health or even just the global economy or whomever actually expands, it's really kind of important to understand that distinction of where it came from and why we use it. When we look at international, we're really oftentimes talking about historically almost like a bilateral relationship, meaning it's international, meaning it's one entity going to another, crossing an international border or whatnot. Global, when we actually start talking about it, is much more broad and inclusive, and I think that's actually really the distinction where we've gone kind of from international health to global health and addressing that, because it's not just a problem of outside or the other or them, but it really is something that it's a development or it's an issue that's globally, meaning that U.S., where we live, are just as much affected as sub-Saharan Africa. And while the differences and the stages of development may be different, the issues are oftentimes the same. And I think Terry even alluded to that at the same time. I mean, people actually, there are patterns in which to follow. So other things people oftentimes think about when they think global health. I mean, some people may think Bill and Melinda Gates, or other advocates that might actually be interested in global health that may not come from that field. I'm certain many of you guys have read, and will identify with certain people that have actually been great voices for global health itself, including celebrities for that. So I think when we talk about global health, I think we really have to draw upon what is public health, and is there a distinction? I know this is a busy slide, but I've actually highlighted certain things. This comes from Winslow, who was actually one of, I wouldn't say the founder of public health, but one of the key fathers of public health. Really founded Yale's School of Public Health back in the turn of the century. But was really trying to define, when this whole concept of public health came about, really what is the aim? And so really what they're looking at is prevention of disease. It's a community effort. It's focused on education and around some sort of organization of services, and it actually is embedded within the social machinery, meaning it's basically all of us. And to actually talk about something as being a birthright, that health is at some point a human right. So when we actually try to define what global health is specifically in kind of this public health sphere, what is this true then distinction between global health, international health, and public health? And we have some people that will argue, while we've kind of created this concept of global health as something new, it actually is truly embedded within public health. And in some ways, you can actually say global health is public health, and we've kind of compartmentalized it in some respect. And I think that is really one of the important things. I think that maybe where we can actually draw some distinctions with global health, it's actually recognizing that it is truly global, that it's not just in one site or one location or one even discipline. And so I think really when we talk about global, it's actually not just about health of all peoples around the world, but it's actually looking at all the different influences of the different disciplines that are not even just health related that influences it. Again, these are kind of examples of how someone, the different disciplines from various walks of life can actually get involved in global health. You have the academicians who may be actually more interested in actually studying the health problems themselves. You have administrators that are very interested in looking at how to organize and operate health services. You have advocates that really want to promote that viewpoint of equity, of altruism, whatnot. Anthropologists that really want to study the human customs and behaviors. You have the biotechnologists. You can go down the list. I mean, even some of these non-traditional areas where you think of like the businessman or a pharmacologist or a politician, I mean, they all have some sort of role to play within the larger frame of global health. So when we look at this, we want to we describe kind of what is global health in some respects. What is this health system in which we work? We kind of understand it just by virtue of actually living and breathing and working in that side. But I think it's important to have a concept of where do we actually fit in and how is it actually defined. Does anybody want to describe, if you had to define what a health system is, what is a health system? You can read on the next slide, I suppose, because I think you have your slides with you, right? So WHO basically defines a health system is basically all those organizations, the institutions, and the resources that produce actions whose primary purpose is to improve health. And I think the key thing is if we have a concept of what a health system is, we may know what the ingredients are, but you also want to have, it has to incorporate the people that you're actually trying to improve the health and the environment and the structure. So it also includes the historical country's history in terms of whether it's political history, even its formation, the pattern of development has great bearing in terms of that health system. The people, not only just the healthcare providers, but also the population in which you're actually trying to treat. Finances definitely comes into play when we actually talk about healthcare financing, but that's actually part of that healthcare system. when we talk about resources, it's not only just the human resources that we're talking about, you, but also kind of the products that we have, the medications, the vaccinations, the different laboratory equipment, the abilities to be able to move things from one place to another to even provide that care, and then the management of that. And there's a whole slew of other things that may come into play. When we look at WHO's thing, they actually talk about 6 building blocks of the health systems, and these are basically what we've mentioned. Health services, performing a high-performing health workforce, the health information system, medical products, vaccines, technologies, which are part of the resource component that you have to actually provide for, a good health financing system, and most importantly, I think in the middle of this all, you have to have some sort of stewardship. You have to have an intact leadership or government structure, and I think the important thing is that it is a dynamic process. It's not that once you actually create these and put these in place, that it actually just runs and that it doesn't change, but it's actually dynamic, and all of these things actually change. And this is even within our healthcare system in the U.S. You can see it. We've gone through lots of healthcare reforms and iterations of that. We have the ACA, and we're actually learning about doing that. If we were to put this together in kind of a schematic, this is actually how WHO does it. There's the middle portion that doesn't necessarily project, but I mean, you have these building blocks, and then you have basically the goals of what you're actually trying to provide for when you're actually talking about health. So you're really trying to improve kind of the health overall, but you want to make sure that whatever system that you have in place, that it's one responsive to the needs, that it actually provides some mechanism for social protection and financial protection, and that you're actually improving the efficiency such that you are able to then overall improve not only the health of the people, but then also potentially the health of the country overall. However, we know that there's plenty of challenges that health systems face. So there's things in terms of really when you're trying to put forth a health system, how are you actually going to actually put that forth? So some common challenges that systems face: coordination. You may have competing non-aligned agendas or objectives from one entity to another. Where does the role of funding and finances come into play? Duplicity. What do I mean by duplicity is that you may have multiple entities trying to do the same thing, and then all of a sudden it becomes not very efficient because you have competition that kind of comes into play. You have just basically repeating of different efforts. Replacement. What we mean by replacement, especially when we're actually talking about trying to develop health systems, you have, let's say, in Bolivia, you have a healthcare system in Bolivia that actually is functioning how it's actually functioning, and you come in with a project or whatnot and saying you're now going to basically provide these health services. Are you actually replacing that existing health system by actually introducing something else on top of that? So those are other things in terms, and then there's the balance of need. So I mean, how do you actually make sure that you are not replacing something that is already supposed to be there? There may be very different priorities in these different parties. One may be very focused if we're talking about a specific project, and let's say like a humanitarian response. There may be, very different programs that are very focused on providing for security versus providing for just the basic health needs versus providing for the water. And so one entity maybe actually, if they pull all their weight, may only focus on one specific priority, and you're going to have different priorities because of that. And you may not be able to, or you may not have actually established any sort of consensus or set of rules or regulations in which how these health entities actually coordinate or work with. And there oftentimes we face, especially in developing countries, limited resources. How do you actually deal with one, scarce resources, but then also the potential waste of resources that might be very valuable? Other challenges that health systems face, Terry actually kind of alluded to. In essence, kind of what he was describing when we were talking about some of this global development or EM development and kind of how has health changed. It really is what we call the demographic transition and or the epidemiologic transition. And so the demographic is the aging of the population, the change in terms of men or male to female ratios. Epidemiologic transition, the transition from more communicable diseases to chronic diseases, and now even what we call the double burden of disease, where you have both coming into play, and emerging kind of communicable diseases that we don't necessarily know how best to approach, but are definitely learning from it. And so these situational changes will challenge the healthcare system. You may have to change the system in which you actually reside. So the other component, like how climate change may actually play into that, how economic change actually affects that. We see more and more the effect of the global economy. And it's just not only so much in terms of the cost of the price of gas, you know, in your gas station, but also how does that affect kind of the government of certain entities that rely very heavily on oil production. Venezuela, which basically probably had a very good, relatively stable status, but because of oil consumption now is actually faced with resources that they don't have, healthcare that they can't provide for, people that are basically a large growing black market. So what are different strategies for us to kind of build and kind of go for this? There is a, you know, health system strengthening, and this is kind of, I think, kind of transitioning to where we're talking about what is this role of emergency medicine, which isn't traditionally thought of within kind of the global health sphere. Where do we kind of fit in? And I think, you know, while we are also part of the healthcare workforce, there's certain things that we can actually think about in terms of some of the products and some of the ways that we think and kind of the philosophies that we approach emergency medicine that can actually build into health system strengthening. So capacity building, which is essentially, you know, providing training, resources, the systems for these people to function more robustly. Thinking about sustainability, that this isn't actually something that's just basically a siloed, it's in a standalone emergency medicine or emergency department, but how does it actually fit within the larger health system? And oftentimes, just by virtue of, you know, the types of patients that we end up taking care of, regardless of where we are, there are issues of equity. And then actually being effective and also being efficient. And so key things, and I think these are alluded to in terms of why kind of even global emergency medicine fellowship training programs have actually evolved, is really kind of looking at some of these elements of successful health systems. I mean, one of the keys is that you have to kind of be on the ground. You have to engage some of the local partners. You have to build capacity. You want to connect with those people that are the decision makers, the stakeholders that are actually involved. Who is it that you're actually trying to help? And working towards creating partnerships in maybe some of these traditionally non-traditional areas. Civil society. What is the role of civil society and government within this? And core to that is actually thinking, and this draws a little bit on this whole concept of replacement, is that the government, regardless of how functional they are, serves an essential role within that health system in terms of thinking about sustainability, in terms of thinking about building programs. And so when we start thinking about these, you know, we talk about engaging these partners. What are these partnerships, and what does a partnership actually look like? And this is kind of where we start talking about trying to define collaboration. So when we look at partnerships, this is actually really drawing from kind of the business world. You have kind of a whole spectrum of what partnerships can look like. They can be very autonomous, and they can be completely integrated. If we think about the integrated partnership, that's basically kind of like a merger or an acquisition in terms of like one company taking over another. Like United, I think, taking over like Continental or something like that, and now Continental's disappeared. Versus really kind of some of these more autonomous, what we call collaborations, where you still have some flexibility and some identity, but it's really working towards a common purpose. And so it gets to kind of trying to define collaboration. And I think it's important to try to define really what does collaboration mean, because I think that then plays into some of these tangible projects, work that many of these institutions are actually working towards with different organizations. So how would we define collaboration? I mean, in many ways, I mean, it's basically an exchange of information and altering of your activities of what you actually do, and you're sharing your resources to basically achieve a common goal of some sort. But it doesn't necessarily preclude that you lose your identity. You don't lose your identity as Detroit Medical or Wayne State or UIC or kind of Maryland or within kind of in Penn State. But it's really, you know, you work that. But there's multiple different ways of interacting. And I think collaboration is oftentimes at this, how do you build the collaboration, is that there's multiple, you know, there's kind of stages of how you actually can build that. When we talk about collaboration, it's kind of that entity where you actually come to a common purpose to work for. Networking, I mean, in trying to understand this distinction between, you know, what is the difference between a collaboration versus a coalition or even a consortium, and networking, I mean, it basically goes from informal to actually really designating something much more shared and something that you actually really want to work towards, that there's some sort of benefit. And a collaboration is not the end. Granted, it's the end maybe of or to define a relationship, how you're going to actually work together, but it's not necessarily the end in terms of trying to develop like a program or trying to develop global health in and of itself. So collaboration technically is actually more of a strategy. It's not basically the goal, but it's actually how are you going to achieve that program that you're actually trying to do. And you can actually look at this on multiple levels. You can actually look at this actually much closer to home. Trying to start an international EM fellowship. I mean, there's collaborations in terms of bringing groups of people together to try to build on best practices. You can look at it in terms of really trying to develop health systems in areas where they may not have a very robust health system. How do you actually do that? The collaboration helps to build that. Now, some of the cons to collaboration is that oftentimes people view it as they're time intensive, there's competition, there's that kind of, there's the healthy and the unhealthy competition. There's lack of trust if you actually don't make efforts to build that. There is an opportunity cost. You have to invest in a collaboration. You're going to lose some of that autonomy. And if there's no clear that's established as to what you're trying to get out of that collaboration, it's not that it's going to fail, but it has a very high likelihood of failing. And if you start looking at this is actually best taken from kind of challenges of healthcare systems. They parallel very much so. So it's the same kind of challenges to collaboration that are challenges to healthcare systems as well. And so when we start thinking about that, we have to start thinking about, well, what is the role? How do we actually go about doing that? And what is the role of kind of trying to strengthen a healthcare system? And how do we actually supersede that? And again, everybody's interest. There's wonderful ideas and collaborations. If you have too many of them, you basically diffuse yourself, and then you know nothing about everything, and then you don't really have a role to play. So it's very, very important when you think about collaborations to be strategic about it, to think how is it actually going to benefit you, or how is it going to benefit the party or the entity that you're actually working with, and does it actually build something stronger? So how do we then choose some of these collaborations that we want to actually pursue? Is it strategic? Does it align with your existing mission? Is it worth climbing that kind of collaboration pyramid of starting something informally to build some sort of agreement, something that you're actually going to all work towards? And is there an understanding of is the motivation there? Is there something where you're going to value what the product is going to be? Or is there synergy, and can you actually leverage that collaboration for future things? Can you build it into something greater? And there are different ways in which we can actually look at that. You can actually look at it from different entities, so like academic institutions, non-governmental organizations, governments, civil societies, or you can actually look at circles of influence when you actually start looking, from a geographical standpoint, local versus regional versus national versus international, and then even global in terms of actually trying to kind of create something that's actually much greater. So it kind of gets us a little bit to then, where then does emergency medicine and global health and collaboration kind of fit into this? We've kind of talked about really what global health is, where do we fit in within the overall healthcare system? What is the meaning of collaboration, and why does that help, and why do we actually go forward with that? So, where does this intersection actually occur? And I think part of it where this has grown is really when you're actually looking at it. It's really having an understanding of what are the needs and what are the gaps within some of these areas that we want to actually work in, whether it's just EM development versus other areas that we can actually look for. And our opportunities where our expertise can come in, not maybe specifically as emergency medicine practitioners, but also in the way we actually think, the way we actually practice. Areas where I think EM and global health have really kind of integrated is looking at these kind of 4 areas: emergency medicine development, the delivery of acute care in resource-limited settings, disaster and humanitarian response. Research, when we talk about research, is actually really looking at the approaches of how we actually look at these things. And of course, this is not exclusive, but these are trying to find ways of somewhat categorizing the way we can actually discuss some of these things. Specifically, the research area and kind of the area in which I've been actually working in is really looking at how do you actually improve access or the delivery of healthcare in resource-limited settings. And when we talk about resource-limited, it's not necessarily always out, quote, them or out or international, but I mean, if you even look closer to home in some of the environments in which we live, there are areas where we are limited in resources, or at least in terms of the concept. So what are ways in which we can actually approach this in terms of building this collaboration? One is actually trying to be as inclusive in terms of the approach of actually doing some of these opportunities that we look at. And so something drawing from really public health kind of framework is something called CBPR, which means community-based participatory research. It's basically really working with the local partners, with the target audience, with the stakeholders to really form and inform what it is you're actually trying to do. I mean, it doesn't make sense for us to say, you know what, we think emergency medicine would be great in Sri Lanka. So we were going to go out and we're going to basically replicate kind of the way emergency medicine works here in Detroit, and we'll just replicate that in Sri Lanka and it works. It doesn't work that way. You have to be kind of inclusive. The other thing is you want to make sure that it's integrated. And when we talk about integrated, it's really looking at all the other components and all the other disciplines. We don't work within a silo. We have influences from multiple different areas that encompass the economic environment, the physical environment when we're talking about that, and even the social environment. And so integration within, you know, those constructs of where you're trying to work is going to be very important. Thinking about how that impacts in terms of, you know, what we do and what we want to do is just as important. The other thing is actually making this as actually providing an opportunity instead of actually thinking about providing assistance. So instead of actually just us providing the care, it's really trying to give them the skills. And so there's specific areas in which we've actually been able to do it. So from funding and philosophies of funding, Grand Challenges, which is essentially a Bill and Melinda Gates component where they've actually participated within a larger Grand Challenge grant and or foundation, but also really focusing on capacity building, not only just in the practice setting, but in research, in the service area, in education. And then looking at it from more of a systems approach. We don't, you know, again, this is a healthcare system. We fit within that. How does it actually make sense within that healthcare system? And I even pretend to actually call this, you know, this effort into something called preventive emergency medicine. Really thinking about, you know, our emergency care that we provide oftentimes is not just the emergency care, but it's really actually addressing why is it that that person has actually ended up in the emergency department, and really addressing some of these concepts of preventative emergency care. And, you know, how do we decide where and what we're going to do and how we're going to collaborate or what projects we're going to do are oftentimes dictated by the things that actually surround us. So, current events. So you can see, you know, historically, you know, this can actually dictate in many ways, you know, where we actually get involved. You have malaria, dengue, chikungunya, now Zika. I mean, that actually helps us kind of frame in terms of how is it that we're going to actually collaborate, who it is that we're going to collaborate with, where, and when. I mean, we saw, like, you know, a couple of years ago, it really was chikungunya. Now, you know, with Zika virus coming along, that also impacts not only the Latin American, Caribbean countries, the Polynesian, Southeast Asian countries, but it's actually impacting us throughout the world. The Brazil kind of Summer Olympics in terms of talk about that, and how do we, and that may dictate in terms of some of these areas where we actually work to collaborate and where our expertise actually can come into play. Another great example of, you know, how certain kind of events can actually play into this and actually looking at health systems is kind of the Ebola crisis that actually occurred a couple of years ago. And I mean, still, even to this, you know, just a month, 2 months ago, it was basically declared that Sierra Leone was Ebola-free, not very long ago. And it's a very tenuous designation. But thinking about how did that Ebola response affect health systems, and what was our role in terms of emergency care, in terms of actually understanding those systems, how to understand how to allay fears, how to actually implement a system of actually response, and actually being able to actually care for not only the potential victims and patients, but also our healthcare workers and protecting them. So, I mean, these are challenges and areas that we are actually oftentimes forced to actually approach. But then we actually have to look at, well, how do we actually then look at these? How can we actually make these much more meaningful and create opportunities? So one of them is the Grand Challenges. And I think the mission behind Grand Challenges. How many of you guys are familiar with something called the Grand Challenges? Not very many. So Grand Challenges basically are these international funding opportunities that are put forth by governments, meaning kind of, I think there's the Canada Grand Challenges that collaborates with Bill and Melinda Gates. You guys are familiar with Bill and Melinda Gates, I hope. If not, I mean, most people are Apple, it looks like, but I too. But I mean, because of their foundation has really made a focus on trying to improve and solve some of the global health problems and development problems. And I think it's really an approach not to necessarily provide kind of a panacea or a Band-Aid on these things, but really trying to solve some of these issues that are sustainable. And so one of the approaches that we try to take from and things that we've actually attempted is actually not necessarily just embedding ourselves there, but really working with some of the issues that have actually come into play that are relevant to the area. As an example, and kind of as an aside, and kind of going into some of these examples of different projects in which I've actually gotten involved in. HIV, you know, not necessarily something that we necessarily talk about in kind of the emergency medicine sphere, but, you know, I've had a project here closer to Chicago in terms of really trying to improve and implement routine HIV testing within the emergency department, partly because of this kind of concept of preventive emergency medicine. The idea of it is, you know, you have a lot of people that don't feel like they're at risk for HIV, but people show up to the emergency department for a variety of reasons, and if you're able to actually test those people, you may be able to actually identify those people that don't know that they're HIV positive and then have an impact on the larger kind of public health issue of HIV. So we're doing this in Chicago. There's programs in Detroit, there's programs throughout the country, but they're justified because there's high prevalence. So then translating this into some of the things in terms of the global health sphere, is this translatable elsewhere? Can we actually move this into a different location? We think about sub-Saharan Africa, very high HIV prevalence. In Kenya specifically, it's still the leading cause of morbidity and mortality. And so could we actually develop emergency medicine within kind of this framework? And so really looking at systems development approaches. So the concept was, can we use emergency medicine and or the whole concept of an emergency department or the way we actually function as a door or an opportunity for public health interventions, and specifically looking at this of HIV care. We know HIV is very high prevalence in Kenya. Can we use this? There was an interest to actually address that. They have a great interest to try to develop emergency medicine, but it doesn't make sense, and their concept of emergency medicine is very much like, well, we need an emergency department to take care of these things. The concept of emergency medicine as it exists in many parts of the developed world, but it doesn't make sense just to start an emergency department unless it actually fits within that framework. So understanding the HIV epidemic and the prevalence of HIV there, can we actually utilize something where there are multitude of prevention services, treatment services, whatnot, to actually introduce and make it fit and help it kind of integrate within the existing system. And so that's kind of actually what we're actually going forward with now, is developing emergency medicine within the context of something that's already in existence within the public health infrastructure. And there has been demonstration where this actually has helped, not necessarily in the emergency department, but also in kind of the inpatient setting there. The other areas, which are not necessarily emergency department focused, is actually when we talk about some of the areas where we can actually get involved. Another program that we've actually been involved in is actually looking at something called community engagement disaster risk reduction. And I think this actually really ensued post-2010 Haiti earthquake. And this is a project that we've actually been involved in for the past now 5-6 years, getting into this. Initially going in for disaster humanitarian response. But I think one of these things, especially as emergency medicine, global health trained practitioners, it's not just about the response that's actually important, but it's also thinking about that sustainability component. How does it actually embed within that system? So what we did was actually post that, kind of wanted to go through this process of, is there any way that we can actually build some sort of a system, and not specifically emergency medicine. So we went through this whole concept of something called disaster risk reduction. Anybody familiar with what risk reduction means, or disaster risk reduction means? A little bit. So this is the opportunity. I mean, you know, we traditionally think about disasters. Most people either think about disaster preparedness or they think about the response. That's kind of what we actually focus on. And I think basically when we talk about this, is kind of like somewhat of a paradigm shift in terms of disasters, is that it's much more comprehensive. If we think about the term risk reduction, it's really not just about that response component, but it's actually looking at how can you then, if you know that a hazard, an event, a disaster is going to occur, how do you then reduce those effects of those disasters that already reside? So it's reducing the exposure to the hazards, it's lessening the vulnerability, it's learning how to manage land and environment, and it's improving preparedness. And the paradigm shift really happened in kind of mid-2000s with what was basically called now the Hyogo framework. And what they identified were 5 different priorities for action, and they were basically these guiding principles for risk reduction. And they incorporate things like the disaster response and preparedness, but on top of that, there's the governance component. There is a risk assessment component. There is an education training component, and there's also this kind of concept of minimizing existing physical vulnerabilities and risk management. And so what we wanted to do in terms of looking and reflecting upon kind of our strengths, not necessarily focusing on policy, not necessarily focusing on emergency department development, but looking at kind of the area of risk assessment and education and training. And part of the reason is actually understanding Haiti in and of itself. I mean, Haiti's history is very rich, and we're not going to go into that. But one of the strengths is that you know, another concept within risk reduction is actually building community resilience. And the concept of resilience is, you know, the ability to bounce back if you actually look at the definition specifically. But when you talk about community resilience, it's really looking at what are those inherent things that the community actually has that allows them to be able to bounce back or return, not just back to normal, but actually be improved. And so those are some of the things that we wanted to focus on. For those of you that are not familiar with what Haiti looks like, it's half of an island, or less than actually half of an island. But this is actually Haiti. Port-au-Prince is right in kind of like the mouth of the bay right here. The earthquake basically hit here, and so largely Port-au-Prince was destroyed. And this is the area in which we've actually been focusing a lot of our efforts, although we are actually in expansion. So what we've done over this process, and this is kind of a nice example of actually demonstrating how does kind of emergency medicine collaborate to fit and work towards something that actually helps within the overall health system. But, you know, wanted to get an understanding of essentially what was down there and what can we actually build and how can we actually scale up a program for disaster risk reduction. So what we did in the very initial phases was we really wanted to understand what was going on in the community. And so we wanted to get an idea of, a couple years after an earthquake, what kind of disaster preparedness activities and what was kind of the feeling and sense of the community, of their understanding of what's been done in Haiti, what is their understanding of disaster preparedness and whatnot, and looking towards kind of, are there gaps that we can actually address? And so we ended up doing a survey in this area, which was a neighborhood in Port-au-Prince. And what we found, we did, you know, from our key informants, government officials and whatnot, is that there's a lack of coordination amongst external agencies. There's a lot of infrastructure gaps. They felt like they should be kind of the ones that are responsible for education and training and preparedness, but they didn't have the capacity to do that. But they felt like they should still be, you know, the leaders within there. On the flip side, with our community members, what they saw is that, you know, there was a need. They had this whole community sense. They really were yearning for help and aid. And the other strength is that they had, while they didn't have very many resources, what they did have is very strong social support and family support networks. And so with the cobbling of the two, bringing in this whole concept of kind of our kind of disaster framework, we wanted to basically create something that gets down to the community level. So again, not at the emergency department level or hospital level, not at the policy level, but can we translate some of those concepts that we actually bring down at the community level? Because when something does hit, who's first hit? The community. And where do you actually get the services last? It's actually at the community. So what can we actually do to actually build this? And so what we ended up doing was essentially creating a disaster risk reduction training curriculum. And it's intended to actually train community leaders. And what we wanted to do was actually test different activities that would actually achieve the lessons that we wanted to do. And the result of that was this training program. This is actually our first cohort that we actually trained that we're still very much involved in. But the approach of this was to actually think about this as a train the trainers curriculum. We created a module or format that really accomplished three different content domains. The first area was defining the issue. So you want to make sure you define what the issue is so people know what that means. So what we did for that was defining hazards, risks, and vulnerabilities. We used different activities that are drawn from Hyogo Framework, drawn from the UN disasters committees, drawn from our own understandings of disasters and actually identifying what those things are through different activities. And then the second component of this is actually really what are those existing assets and resources that actually exist in the community. And so we wanted to work into not necessarily lecture format, but very much an activity format, trying to get them to think about what already resides in their community. So often these people think, well, you know what, there's nothing available for us because, we have nothing. Everything's been destroyed. But there are inherent things that actually reside. Things that we actually try to say in terms of intact structures that are there. Ways that we actually try to demonstrate this was actually looking at ideas like the mapping exercises to basically map what their community actually looks like. Where do those actual resources actually reside? Getting them to think about those things. And then finally, to look at having them really solidify and ground ways in which they can actually disseminate this. How can they actually do something like that? An example specifically for this risk reduction program was having them create what we call household action plans. What happens when you get separated or there's an event? And also things like next step action plans. It was a mechanism for them to start thinking about, so now they learned this, they know what it means, they know what assets they actually have. How are they going to actually bring this to their family? What is it that they're actually going to do? And actually giving them strategies of how to actually facilitate this. And so this is an example of a next step action plan that was actually filled out, and we actually have them identify who, what, where, when, why, and when is it that they're going to do it, such that we can actually follow up with them and say, what is it that you've actually done, and what can actually we work with you. The idea of this was to basically identify community leaders that would then take this and then it would be removed from us, meaning that we would not then be the leaders training, but it would be the community members that would actually train. And one of the highlights of this so far has been, within our initial cohort, there was a group of 5 that actually participated that as a result of this created their own Haitian organization. They are now a nationally recognized Haitian organization. This is their name in Creole, which Groupe Cap Travail pour Réduction Risque des Désastres. If you speak French, it actually phonetically sounds like French, but when you read it, it does not look like that at all. But essentially, it translates into the group that works towards reduction of risks towards disasters, GTRID as they're known. To this day, they have trained over 200 people with the curriculum that we've actually trained, and we're actually using them as facilitators to actually expand. And so this is kind of what you want to see, is like, can you embed something like this to give them the skills to then be able to actually expand? And so, as part of that process, we wanted to make sure that it was also acceptable and adaptable in different settings and entities. So we've also trained multiple different cohorts of people in different areas within Port-au-Prince, recognizing that there's different social dynamics, there's different kind of social settings, there's unique kind of political undertones in certain neighborhoods that do these same concepts actually still apply. And they do. And in addition, within working with them, has actually helped us to define the entire curriculum, which incorporates other things that are basically some of those basic services that, not as untrained health professionals, lay health people that they feel like they need. Looking at first aid, how do you approach mental health and disasters? Looking at the role of vulnerable populations, and more specifically women in disasters, and how do they actually play into that? And so as we've been growing this, we've demonstrated how, one, that we can actually work and actually build a program related to that. It's still based in its core in kind of some of these emergency medicine kind of approach principles, but it's actually translated down to the community level that can actually help to augment the larger health system. Our next phase is that we're actually expanding. And so we're expanding through the YMCA Haiti. They have, and we're using a business model, so really talking about the different disciplines, and we actually get, when we talk about building emergency medicine systems or looking at global health, is we're drawing from some of these business principles and actually drawing from our School of Business of actually creating an expansion scalable model that's actually sustainable. And so what we've created is something called, they call it the open innovation paradigm. And what it essentially is essentially an embedded program. You have one entity, our risk reduction curriculum, and another entity, YMCA, that have strengths on either side. And so within, we provide the content curriculum. YMCA provides the infrastructure to be able to scale up. They have sites throughout the entire, 8 different sites throughout Haiti, and we're building through them, training their leaders such that then they are able to then expand, and then that's how we can actually spread in terms of the content, the concept, and actually be able to actually provide some disaster risk reduction, some of these emergency kind of concepts to the people in and of itself. So, I mean, in terms of trying to summarize really, you know, what we talk about, I mean, oftentimes people don't necessarily think about global health and emergency medicine in the same kind of sentence. It's oftentimes somewhat, they don't really see where this public health population domain comes into emergency medicine when what we're doing is actually acute care and actually just-in-time kind of care. But I think when we start drawing on looking at collaborations, how do we actually collaborate? Where do we have strengths? And what are the skills that we actually can provide? Some of it is actually in kind of that planning phase. Some of it is actually in the expertise in terms of content. Some of it is actually in the approaches to care that could actually translate not only into clinical care, but into management and into administration that I think are our strengths. And that's actually really what kind of helps us to kind of define where do we fit within this larger framework of public health. And so I'm just going to end with one quote, because oftentimes we think about global health as being this gargantuan kind of challenge and something that we're not necessarily going to be able to achieve. We're not Bill and Melinda Gates. But it starts small, and I think it really starts with kind of a passion that people have. And I think that's one common thing, at least one common thing that all of us as presenters today have, is the passion for global health and really to try to disseminate our best practices. So thank you.
I think we have like a 5 minutes break, so we're running late a little bit, so we'll cut it down to 5 minutes, and then we can reconvene at 10:20. I think Dr. Holliman will be talking now.